So tetralogy of Fallot, as you all know, is a condition with 4 abnormalities. There is a large symbiotic VHD caused by overriding of the aorta, pulmonary stenosis, and right ventricular hypertrophy with cyanosis and clubbing. Now, patients with tetralogy of Fallot have a sudden mortality. When Michael Ackerman looked at mortality rates among children aged 1 to 14, he found that heart disease was at the bottom as far as rates are concerned, just above influenza and pneumonia. But if you look at what happens over the ages as the child grows old, you will find one of the commonest arrhythmia, which is found till the ages of 35 to 45, is the ventricular arrhythmias, ventricular tachycardia and ventricular fibrillation, right up to 35 to 45 years of age. If the patient survives more than that, and this is what is responsible for sudden cardiac death in patients with tetralogy, and if they do survive beyond that age, most of the arrhythmias they do have at that time is atrial fibrillation and intra-atrial reentrant tachycardia. It has been found that ventricular tachycardia and ventricular fibrillation are one of the risk factors for sudden cardiac death in patients with tetralogy of Fallot. The long-term incidence of sudden cardiac death in tetralogy of Fallot has been given by this expert consensus statement in 2014 from these authors, and they found that the incidence per decade varies from 1.2 to 3% in various studies. So it is not exactly negligible. There is some sudden cardiac death, and this can be attributed to the surgery which is done in these patients at a very young age, which involves, in earlier years, there used to be a ventriculotomy in the anterior part of the right ventricle, and this in turn contributed to a prolongation of the action potential duration and a dispersion in this action potential. Apart from that, there was a reduction in the conduction velocity and caused by fibrosis and lateralization, and this created an arrhythmogenic substrate in patients with tetralogy of Fallot. When you look at long-term outcomes in patients who had undergone surgery, surgical repair of tetralogy of Fallot, this particular article, which was published quite some years back, during the time when ventriculotomy was common, it was found that almost half of the patients died from sudden cardiac death, out of the total of 22 deaths in this particular paper. So what is that causes the sudden cardiac death in these patients of tetralogy of Fallot who have undergone cardiac surgery? If you look at the surgical result, this is a midline sternotomy view of a patient with repaired tetralogy of Fallot. This is the RVOT patch. And what happens when there is an RVOT patch in these patients is there is chronic right ventricular volume overload because of the pulmonary regurgitation, and this causes RV dilatation, hypertrophy, and dysfunction. And there is right bundle branch block in these patients of tetralogy of Fallot, which induces ventricular dyssynchrony, and that can contribute to LV dysfunction along with cyanosis and volume overload, which contributes to diffuse myocardial fibrosis. On the other hand, the right ventricular outflow tract patch sequelae gives rise to increased RV pressure. There is localized remodeling and fibrosis, and aneurysms may form. The RVOT patch will contribute to dyskinesia, and there are slow conducting zones. All of these contribute to an adverse electrophysiologic remodeling of the right ventricle in these patients, and this causes the substrate for ventricular VT and VF, and that triggers the sudden cardiac death in these patients. So when you look at how to assess these patients for the treatment, which are the patients who are at risk of sudden cardiac death, they looked at various attributes to these patients. So and gave it some points, like in this particular paper published in 2008 by Paul Carey, who is one of the leading contributors of follow-up of congenital heart disease patients. They gave that the maximum points were given to left ventricular end diastolic pressure, a point of about 3. And they treated patients and stratified the risk based upon these points. There were, over a period of years, and more recently, there has been they have added other risk factors to these particular to identify which are the patients who are liable for sudden cardiac death. And most important they found now is QRS fragmentation, which is an indication of myocardial fibrosis, is an important indicator of sudden cardiac death. When you do an MRI, the MRI can give the scar burden and late gadolinium enhancement of more than 25 centimeter cube, that is which gives a 72% sensitivity and a specificity of 81% as a risk factor for sudden cardiac death. Myocardial strain and rotation patterns seen by MR angiogram, cardiac MR, LV systolic circulatory circumferential strain rate, QRS vector magnitude, and exercise stress testing. All of these contribute to identifying risk among patients with TOF. And more importantly, RV dysfunction. And when you have RV dysfunction in patients with tetralogy, sooner or later it interacts with the left ventricle and induces dysfunction in the left ventricle, because as you all know, the myocardial fiber is one single sheet which during embryological development gets folded to form the different chambers of the heart. If you have a child who has undergone surgical repair of tetralogy at an age greater than 6.5 years, that is another risk factor for sudden cardiac death in tetralogy. Residual right ventricular outflow tract obstruction after surgery with a right ventricular mass by volume of greater than 0.45 grams per ml is also a risk factor for sudden cardiac death. Pulmonary regurgitation, as we just mentioned earlier, will cause a right ventricular dilatation and dysfunction, and a right ventricular end diastolic volume index of greater than 160 mils per square meter is an important risk factor for these particular patients. Now, there was an indicator study which looked at patients who had undergone pulmonary valve replacement because they had severe pulmonary regurgitation and right ventricular dysfunction. And they reasoned that if these people who have now undergone the surgery should do better, and they will not have as much risk of sudden cardiac death as those who have not undergone the surgery. So they had two groups, control and thing. But to their surprise, they did not find any improvement in those patients who had undergone the surgery. It's probably because the surgical treatment was done in a little later stage. This was the indicator study. So they did not find any decrease in sudden cardiac death in these patients. So it shows to prove that it's not only important to undergo the pulmonary valve replacement, but it has to be done at quite a young age. Now, this is a typical ECG of a patient of tetralogy of Fallot, and there are some important risk factors which can be seen in this particular ECG. A very wide QRS greater than 180 milliseconds, a tall R in V1 of an RR pattern which shows of increased right ventricular systolic pressure, and a splintered QRS. As you can see here, the QRS is splintered into various waves within the QRS. All these are indicators of a higher risk of sudden cardiac death. And when the presence of ventricular tachycardia is another component which shows of greater risk. Now, if you look at the risk score to predict mortality in patients with tetralogy of Fallot, a number of mortality risk factors have been taken. Presently, even a recent publication in JACC has come about MR scanning to know about late gadolinium enhancement, And they have given various scores for both right and left ventricle. As you can see, they have given a score of 40 for the right. Left ventricle is about 60. Can you give me another pointer? 6. And for looking at ejection fraction, right ventricular ejection fraction, a maximum possible score of 10. Left ventricular ejection fraction, maximum score of 12. And a peak oxygen uptake of 6. Battery change. Peak oxygen uptake of 6. And the BNP, if the BNP is greater than 127 nanograms per liter, it is 12. And sustained atrial arrhythmia has a score of 8. And if the patient is over 50 years, the score is 6. So putting all these scores together, the maximum possible total is 100. And based on the score of over 100, you can classify them into three groups. To 3 groups, that is and low risk, intermediate risk, and a high risk. If you have a score of greater than 51, it comes under the high risk, and the percentage of patients who are at mortality per year is about 4.4% per year. So these are the people who will benefit. As you can see here in the accompanying predicted survival chart graph, you can see that the red line, the number of patients whose predicted survival is least in the patients with the high risk. So these are the patients who will benefit from an implant of an ICD and targeted therapy to prevent sudden cardiac death. So what about ICDs in tetralogy of Fallot patients? As we just mentioned, the patients with high risk may benefit from this. And secondary prevention, when there is a survivor of a cardiac arrest or ventricular tachycardia, there is no doubt in our mind, they do need ICDs. But in primary prevention, what is the thing? So we look at dysfunction, LV dysfunction, non-sustained VT, a QRS duration greater than 180, inducible sustained VT on programmed stimulation, extensive RV scarring by MRI or diastolic dysfunction, and if the patient has a syncope of unknown etiology with inducible ventricular arrhythmia at electrophysiology study, or in those whom there is a clinical suspicion of VT. Now these are the subset of patients whom which you can think of primary prevention. Remember, inappropriate shocks are seen in 20 to 42% of adult patients of tetralogy who have received ICD. So let's not run in and put in an ICD in every patient. Make sure this patient is at risk and will benefit from the ICDs before they are given. Now, prior to implanting an ICD, one can think of invasive electrophysiology testing, as published in this article by Michael Cohen last year. There is a presumed link between ventricular arrhythmias and sudden cardiac death, which has led to electrophysiological testing. However, one should remember that VT inducible in patients who never had clinical VT has been seen in such thing, and this was very much confounding. The positive predictive value of inducible VT in predicting clinical VT or SCD is about 55% in patients with clinical indication for clinical stimulation. The positive predictive value of only 25% when routine screening. Supposing you do a routine screening for all tetralogy of Fallot patients, ignoring whether the patient is at risk or not, then you find that the positive predictive value falls drastically to 25%. So aggressive, invasive EPS in asymptomatic patients is questionable and should be avoided. The other useful thing about invasive electrophysiology study in tetralogy patients is to map the isthmuses of slow conduction. As we all know, during the surgery, particularly in children, young children, right ventricular outflow tract patch is put to widen the patch because the annulus of the pulmonary valve will be very small, and as the child grows, you need a bigger annulus, and therefore they put a patch. So there are 4 anatomic isthmuses that are identified which are related to VT in repaired TOF. First isthmus is bordered by the tricuspid annulus and the scar or patch in the anterior RVOT. The second one is between the pulmonary annulus and the RV free wall incision or RVOT patch but it's sparing the pulmonary valve annulus. The second isthmus is now not seen much because now nobody does a right ventriculotomy for repair of tetralogy. It's all through the transatrial approach. Isthmus 3 is between the pulmonary annulus and the upper margin of the VSD patch, and isthmus 4 is between the VSD patch and the tricuspid annulus in the small subset of patients of tetralogy who have a muscular VSD, which is quite not very common in tetralogy because most of it is subaortic VSD. Right? RF ablation at these sites can rid of VT and have been achieved in 75% of cases. As you can see in this particular study by Mitchell Cohen, they have done the mapping and they have found a 13 millimeter isthmus there between the two gray zones, and this was ablated, and the VT was terminated in this. The VT picture is seen on the other side in this patient. It was terminated. So the management decision of sudden cardiac death risk factors in tetralogy is by looking at demographics, clinical history, electrocardiogram findings, and ventricular assessment, and stratifying the risk. And based on the risk, the high-risk patients will receive ICD. Intermediate risk undergo invasive testing before they go. So the take-home message I would like to, what impressed me is that tetralogy of Fallot post-repair has sudden cardiac rates of approximately 8.3% in some large study by Clayton in 2009, published in JAMA. White QRS greater than 160 millisecond and splittered QRS on an important risk factor. However, this white QRS duration should be greater than 180, not 160. Sudden cardiac death can be avoided by early surgery. Operation should be done before they are 6.5 years of age. Preventing RV dysfunction and the contributing LV dysfunction by pulmonary valve replacement should be done when right ventricular systolic pressure is greater than 60 millimeters of mercury and right ventricular end diastolic volume index is greater than 160 milliliters per square meter. EPS can guide in selecting patients at high risk for ICD therapy. Mapping of isthmus will facilitate RF ablation and prevent the triggers of ventricular tachycardia. Inappropriate shock, remember that inappropriate shocks are seen in 20 to 42% of patients. So thank you for your patient listening.